Hi, I'm Lorna Khan.
And I'm Rashawn Cabral.
So we're gonna do our presentation on amniotic fluid embolism. So we're gonna talk about what it is, the causes, signs and symptoms, and a case study. So I'm gonna start off what it is. Amniotic fluid embolism is an embolism caused by an entry of amniotic fluid into a maternal circulation. This rare event may occur at any gestational age that most commonly occurs during labor delivery or in the immediate postpartum period. The contents of the fluid such as shed, fetal cells, meconium, lango, and vertex may provide pulmonary and cerebral emboli. Although the causes of amniotic fluid embolisms are unclear, it is associated statistically with advanced maternal age, cesarean birth, peripartum vaginal bleeding, and rapid labor. Maternal collapse is thought to represent an anaphylactic reaction to fetal contents in the maternal circulation. So, affected mothers may notice a feeling of anxiety, dread, or agitation as they become hypotensive, and bradycardia, apnea, cardiac arrest, and DIC, which is disseminated intravascular coagulation, commonly occurs. There is no known means of prevention, and disease-specific treatments are currently unavailable. So, amniotic fluid embolism, maternal death occurs in 20% of cases.
So I'm going to present a case study about amniotic fluid embolism. So a 38-year-old woman, she was about 148 pounds with moya-moya disease. So moya-moya disease is a rare disease that's a progressive cerebral vascular disorder caused by blocked arteries at the base of the brain in an area called the basal ganglia. So the patient had moya-moya disease and she was scheduled for a repeat cesarean delivery. She gave us her history of frequent transient ischemic attacks during hyperventilation associated with moya-moya disease. So ischemic attacks are like mini strokes, and with the event of the signs and symptoms of a stroke, but which go away with a short period of time, and they're all due to temporary lack of adequate blood and oxygen to the brain. So therefore, a cesarean delivery under general anesthesia was planned to avoid ischemic attack during labor. She was not taking any herbal preparations or anticoagulants. Laboratory findings on admission were as follows. Normal EKG and chest x-ray, hemoglobin was at 10.7 grams per deciliter, and no urinary glucose or protein. At 38 weeks and 1 day of gestation, cesarean delivery was performed under general anesthesia without complications. The patient's trachea was extubated and returned to the obstetrics ward. 4 hours after cesarean delivery, vaginal hemorrhage increased rapidly. The patient's systolic arterial pressure decreased to 80 milliliters of mercury, and the heart rate increased to 148 beats per minute. Ultrasound imaging and computed tomography CT revealed a large retrovesical hematoma. The patient was transferred to the operating room for emergency laparotomy, and general anesthesia was induced. A few minutes after skin incision, airway pressure increased suddenly. So the SpO2 declined gradually, arterial blood pressure became undetectable, and the heart rate was absent. Immediate cardiopulmonary resuscitation was initiated. Spontaneous circulation resumed after administration of 1 milligram of epinephrine, but additional bolus injections and continuous epinephrine infusion was required to maintain spontaneous circulation. The uterus was atonic and swollen to the size of a person's head. Although a B-Lynch suture was attempted, a tonic hemorrhage remained uncontrolled and the decision to perform hysterectomy was made. A large amount of bloody fluid was obtained from the surgical site and the blood did not clot. Bleeding from the nose, the oral cavity, and the tracheal tube was observed. Coagulation tests, including those for FTP, D-dimer, and fibrogen, showed that fibrogen had decreased to less than 50 milligrams per deciliter. We administered 44 units of packed red blood cells, 44 units of fresh frozen plasma, and 55 units of platelets, and 8 grams of fibrogen, and 3,000 international units of antithrombin concentrate during the surgery. Intraoperative anesthetic course and the result of coagulation tests are shown. After hemodynamic conditions stabilized, hemorrhage from the nose, the oral cavity, and the tracheal tube gradually decreased, and the patient was transferred to the intensive care unit without extubation. And extubation is the removal of an endotracheal tube. So that's the case study for the amniotic fluid embolism case study that we wanted to present. So thanks for watching.
Thank
Bye.
you. Bye.